Good morning or good afternoon, everyone, and welcome to the joint webinar of the American Thoracic Society and European Respiratory Society to discuss the topic Perspectives on Management of Sleep Disordered Breathing in Infants with Robin sequence. My name is Iris Perez. I am the chair of the Journal Club for the Sleep Respiratory and Neurobiology. And I would like to introduce Dr. Verhulst Stijn.
Hello, good afternoon, everyone. I'm Stijn Verhulst. I'm a pediatric pulmonologist and sleep physician from Antwerp in Belgium. And I'm also welcoming you to what will become a very interesting webinar. And I'm also representing the new pediatric sleep and NIV group of the Pediatric Assembly of the European Respiratory Society. And I would like to introduce our Secretary of the Assembly, Refika Ersu.
Hi, welcome everyone. Such a pleasure to be in this meeting. I'm a pediatric respirologist and a sleep physician. I work at Children's Hospital of Eastern Ontario in Canada. And I'm the current chair of ATSF and Webinar Committee and as Stijn mentioned, the secretary of the ERS Pediatric Assembly. I'm very pleased to be in the company of experts in this area. As the difficulties with breathing and feeding are often very complex to manage in Robin sequence, and there are very significant variations in clinical practice, our panels now will discuss the approach to management of these children from their center's perspective and will introduce us to their practice. So we'll start with Dr. Evans, who is an associate professor of pediatrics at University of Washington and attending physician on the inpatient and clinic units in Seattle Children's Hospital. Take away, Dr. Evans.
Thanks, Refika. Can you see my slides okay? Thanks, and thanks for including the pediatric perspective. And I'm excited and nervous to go first, but interested in learning the various other perspectives. So I'm a pediatrician. I'm one of many pediatricians on a craniofacial team, and I am at this little star in the Pacific Northwest, serving a pretty large catchment area, patients locally, but also coming from a distance, for example, all the way up in Alaska. We take care of many babies in the clinic as well as in the inpatient unit, and certainly John ear anomalies are a population that we care for. And I see about 15 to 20 new babies with Robin sequence each year. As you can imagine, the care across the US varies quite a bit. I'm going to share a little bit about our perspective. So Robin sequence is a really variable, heterogeneous condition. And I've been fortunate to work alongside an international work group to sort of narrow down and agree upon with consensus techniques, the initial diagnosis and workup, but also to collaborate on continued opportunities for improvement in this important population. I worked together with the team to sort of develop these initial assessments, focusing on the involvement of the jaw, the base of tongue and glossoptosis, as well as airway obstruction. And while strategies to sort of quantify airway obstruction in this population vary tremendously, we are using more and more sleep studies in this population to really try to quantify and understand both the severity, but also the effectiveness of our interventions. There's also some newer classifications that have come across. We have not started using the micronaps from our colleagues in Boston. This is a recent publication, but one thing that I think is pretty cool about this classification is the inclusion of feeding, growth, and other comorbidities or syndromes to allow for sort of more comprehensive classification. I think this will be really important for comparisons and especially research studies in the future. So what do we do for our infants with airway obstruction who need an intervention? Typically, if they're in the hospital, we have a whole host of tests that you'll hear from our other colleagues today, starting obviously with the physical exam at the bedside. And when it comes to sort of thinking about who needs an escalation in their airway treatment to achieve some degree of stability and able to discharge home, typically we're thinking about escalating that treatment if they have ongoing work of breathing or STIR or CO2 levels that are rising, or from a serum bicarbonate or total CO2 that's 28 or higher. Oxygen desaturations requiring an intervention, not gaining weight appropriately. And when we do a sleep study, we're looking, obviously in partnership with our sleep colleagues, at the quality of their sleep architecture, their ability to get into REM sleep, but also their obstructive apneas and their gas exchange. And we are using this more and more, like I mentioned. And then we typically use a bedside awake laryngoscopy to understand the base of tongue airway obstruction, as well as identify treatment targets, and certainly to also identify comorbidities that might negate the success of a focused base of tongue intervention. And all the while, we have a family who's there, and they're hoping for a baby who's got safe and satisfying eating, preventing apnea and choking, and ultimately, of course, returning home. We know from sort of surveying the international craniofacial community that continuous oximetry and sleep study are the sort of most common tests utilized to determine if airway management needs to be escalated. And in our institution, we certainly are using sleep studies now pretty regularly, as I mentioned, but we also know that there's a lot of different types of sleep studies, and the interpretation is complex, as we'll get into with our panelists. So the sleep studies that we perform at Seattle Children's for infants with rub-band sequence are in the NICU or in the medical unit. We have a robust sleep lab led by Dr. Maida Chen and really skilled sleep technicians. We try to achieve at least one REM cycle supine if this can be done safely and the baby tolerates. And then looking at the therapeutic effects of positioning and low flow oxygen. We use the AASM scoring and certainly closely work with our sleep physicians to understand the burden of their sleep disorder breathing. And we know that sometimes waiting for a spot for an inpatient sleep study can be a challenge, as well as I'll talk about some of the complexities in trying to interpret the data for babies with real airway obstruction who may not be able to sleep well. Fortunately, there's emerging referent data by which to compare these neonates and infants to that y'all are probably well aware of. So I wanted to show some real data just to sort of highlight the complexity. This is a convenient sample, the last 14 babies with rub-band sequence, with or without associated syndromes under 2 months of age, hospitalized for management of their airway obstruction. And you can see here, I've gone from sort of the least severe obstructive apnea-hypopnea index to the most severe in that list, and the average obstructive AHI of 67 per hour with a pretty broad standard deviation. Interpretation of these neonatal sleep studies, I can't do justice to how complex this is and really requires a team approach. But as you can see here, many of these babies, we weren't able to assess REM, supine, or they weren't able to achieve much REM sleep. And so I think that the sleep studies are really most useful, especially if the severity is unclear, if the pattern it's confusing, or if we need that additional data really to guide shared decision-making with our team and with caregivers. So our treatment approach here in Seattle is really to minimize impact of their upper airway obstruction and maximize function and quality of life. And we start with the least invasive interventions while in the hospital. That includes low flow and high flow nasal cannula, and then sort of escalating towards a surgery if absolutely necessary. But really our protocol has evolved over time to avoid surgery and allow for natural airway growth and really find treatments that are accessible to this sort of wide geographic range that we serve. And ultimately, we want babies who are able to be at home breathing and eating. This is our protocol that's really just sort of a framework for our approach here in Seattle that was developed sort of with a community to come to sort of consensus on the first steps for the baby who needs to be in the NICU with base of tongue airway obstruction. And historically, we have utilized prone positioning for home, oftentimes with a sleep study prior to discharge. But I'll tell you a little bit about how our approach has shifted. We also have experience with the nasopharyngeal airway. And I think one of our concerns, as we'll talk more about prone or sideline positioning at home, is that risk for residual obstructive sleep apnea, and of course, SIDS. In Seattle, jaw surgery has while I think it's popular across the US and there's some quality evidence regarding outcomes, typically we use this as a treatment to avoid tracheostomy if less invasive treatments have not been successful to stabilize the airway. We know that MDO will decrease the need for a trach and a G-tube and make the airway bigger, but it can cause abnormalities in dental eruption, the temporomandibular joint, as well as disturbances in facial sensation. And we know that MDO in infants with Robin sequence does not activate mandibular growth or really decrease the need for later orthognathic surgery. Oops. So we've been really excited to try to innovate and partner with our colleagues in Tübingen, Germany, to bring a therapy here that would allow us to effectively treat airway obstruction and avoid surgery. The Tübingen palatal plate, we started our program in August of 2023. Our colleagues in Stanford coined the term orthodontic airway plate here in the US, so you'll probably hear both of those. This is our approach, and I won't go into detail here. There's many papers from our colleagues in Germany about the process of this, but our approach starts with an impression and addition of the retention wires, bending of the thermoplastic or the tail or the spur. We use imaging to help improve the fit, laryngoscopy to check the placement of the spur, and then encase it in acrylic and start sort of the training at the bedside. This is a custom appliance that's removed daily, typically lasting for anywhere between 4 and 6 months of treatment early on. And this is just some images showing sort of that virtual try-in and how we try to get to the best fit and function as early as possible using our available imaging. We've also worked with our colleagues in otolaryngology imaging and radiology to utilize 4D CT to really understand the mechanics of upper airway obstruction. This is a baby with Robin sequence, and here's some just sort of representative static images from the 4D showing on the top that nasopharyngeal obstruction from the base of tongue and posterior oropharyngeal on the bottom. So I think that there's some really exciting potential research avenues for this work and understanding airflow dynamics in this population and how that correlates to function. We continue to use laryngoscopy, not only at the time of delivery, but for spur modifications. And then obviously if there's any residual obstructive sleep symptoms, in this image right here just shows, you can see that spur scooping the tongue forward, opening up the airway. We also continue to use sleep studies throughout the course of treatment to assess ongoing efficacy and certainly after the graduation from the plate. This is our Seattle Children's protocol, typically a few days in the NICU, a few weeks on the medical unit, followed by a few months in outpatient with frequent team follow-up, working on sort of all aspects of the baby's health in addition to their breathing. And these are our early, very sort of recent hot off the press outcomes for the babies we've treated with orthodontic airway plates, some of who are currently in therapy. So on the bottom, you can see the 10 who've completed therapy, and a little bit of information about the population that we've treated, who have been, some isolated patients, but some with associated syndromes. And we've been really excited about the significant and sustained improvement in the obstructive apnea indices. And the beginning on sort of the left, you can see before their OAP, their baseline sleep study throughout the course of their treatment to their final sleep study with their OAP out. And that's sort of a dramatic improvement. Obviously, the obstructive apnea hypopnea index is not the only metric that counts, but one that I wanted to show here. And these are babies who were on high flow CPAP with positioning prior to treatment and are now at home supine. So obviously, as a pediatrician, the rest of the baby also matters. And just wrapping up, I wanted to share that, and in line with our airway treatments, we're working really closely with our feeding and developmental therapists early on in our protective strategies, especially around procedures and endoscopies, creating a developmental playbook to continue at home with community therapists, and then working really closely on oral stimulation and skills, those feeding skills, to be able to ultimately wean off of tube feeds, which is really, I think, most likely in the isolated population. And we know there's a lot more outcomes that need to be tracked, and excited to partner with folks in doing this prospectively. And really this early infant time, I just want to highlight this very small fraction of their sort of longer term craniofacial care. And I want to say, and in closing, thank you to my team, who has been sort of essential to be able to sort of grow and innovate and continue to improve together. And there's an international consensus meeting in Paris coming up. And so please join us for that and reach out with any questions.
Iris, you're muted. Iris, you're muted.
Thank you so much, Dr. Evans. We would just like to remind everyone that you can put in your questions in the chat, and we will be monitoring, and we can address them all towards the end of the after the last speaker. So our next speaker is Dr. Christian Poets, and he is the chair and medical director and professor in the Department of Neonatology at the University Hospital in Tübingen, Germany. Dr. Poets?
Yes, thank you. And I hope that everybody can see my slides. Yes, I see the thumbs up, excellent. I think I can skip the introduction. You all know what I'm talking about here. And the only point I would like to stress, and that's basically continuing where my previous speaker has ended. We need only two tests, basically a sleep study and weight charts to monitor treatment effectiveness for these babies. And you have already heard about whether you call it tubing implanted plate as we do, or call it obstructive OAP, whatever it means, I forgot. It doesn't really matter. It's an orthodontic device that helps the tongue, which is unfortunately placed backwards in Robin sequence babies, to assume a normal position. And thereby it starts a functional treatment as the baby suddenly can breathe normally and can also feed, which is very helpful. And if you look at these two endoscopy pictures, the left one is without the plate, and then here you see the tip of this blue spur, and you can immediately see how nicely and beautifully the airway opens. And this is also shown here in this schematic. And if you look at this very brief video, the baby is certainly in distress without the plate. And it was really eye-opening to me when I first saw that more than 20 years ago, that basically the baby has now the plate and breathes very quietly and peacefully. And this effect is really reproducible. We have now treated more than 600 babies with this treatment, and I can tell you it works. And we had never to do a tracheostomy in babies with isolated Robin sequence, and around 10% of babies with syndromic. They're a different kettle of fish, so to speak. And perhaps the most important comparison to the international audience who may work in centers where they are using mandibular distraction osteogenesis is this very recent study published in the Cleft Palate Craniofacial Journal last November, where we did a retrospective comparison between our sleep study data and weight data and Boston's data. And you see that our length of stay is almost half that in Boston, that the obstructive apnea index, they use the obstructive hypopnea index. We only count apneas, so you can't directly compare them, but it goes down from 26 to 0.4 with the MDO, and very similar results with the tubing implanted plate. And look at the data with regard to NG tube feeding, pre-intervention, the vast majority, or all of them, in fact, And after with the treatment now, MDO, 55% still are fed with tube and only 18% at time of discharge. At the last follow-up in 1 year, none of our infants is still on a gastric tube. And the Z score for weight is normalized at the last follow-up at around 1 year of age. And if you're talking about sleep study, you may ask, why are we just monitoring apneas and not just hypopneas? Yes, you have to double the values to make them directly comparable if you use full polysomnography, but we use only respiratory polygraphy without the EEG, without the EOG, so we can't reliably monitor hypopneas. That's our conscious decision. I am a certified sleep physician, so I know how to do that, but we purposefully decided not to do that in this particular population of babies because they are already so stressed that we want to keep interference with them to a minimum. And to answer the question that had been sent to this panel, how does the unit assess the presence and degree of upper airway obstruction? We use overnight polygraphy and we use flexible awake nasopharyngoscopy. And we use a threshold of mixed obstructive apnea index of above 3 to indicate our this treatment. And we never try prone positioning as a treatment because of this very strongly increased risk of sudden infant death syndrome. And the question, if you're not using prone positioning, what's your next line of treatment? Obviously, the TPP, the Tübingen plate, and we never use surgical options, as already said. And outcomes, we usually want to achieve a mixed obstructive apnea index below 3 at the time of discharge and below 1 at the 3-month follow-up. And we obviously want to have it normalized in terms of Z score. And what I think is really important, and which you have shown only recently and quite nicely, I think, is that it really induces mandibular catch-up growth. This was the banner for our congress we organized about 3 years ago, so prior to the Perez meeting. And you can see how nicely in this baby where the father took a side view every month, how nicely the profile normalized here. And we try to measure that objectively by determining this angle, which we know from orthodontic practices. And you can see how the lines here get very close at the end of the first year of life. So basically, the chin gets to the totally normal position. And that also explains why we have a very low rate of later obstructive sleep apnea in these babies, because they really become anatomically normal babies. And with that, I would like to finish and would like to hand over to the next speaker. Thank you.
Thank you, Christian, for this very interesting overview. It's my pleasure to introduce my colleague, Professor An Boudewyns. She's head of clinic of our pediatric ENT department at the Antwerp University Hospital and also an associate professor at the University of Antwerp. And please.
Thank you, Stijn, for the kind introduction, and also thank you for the organizers to be part of this panel and to discuss the European or ENT perspective, maxillofacial perspective on the management of Pierre-Robin sequence. Well, I will try through this presentation, try to answer the questions that were proposed by the moderators. And so the first is, what is your diagnostic approach? We perform full night video polysomnography. This is typically carried out in the first weeks of life in case of severe symptoms. And otherwise, we do this at 2 months of age because it has been shown in literature that there might be a worsening of sleep disordered breathing in the first 2 months of age. So especially if you do the sleep study very early on, let's say in the first 2 weeks or so, and symptoms are increasing in severity, then it's really important to reassess and repeat the polysomnography at the age of 2 or 3 months to have a good picture and a reliable picture on the OSA severity, upon which you will base then your treatment. The diagnostic criteria we use are those that have been published in the European Respiratory Task Force. So we use the obstructive apnea-hypopnea index as one of the major criteria, but we also look at the presence of bradycardia, and especially when it comes to decision-making on treatment, we feel it's very important to take also the clinical signs into consideration, the degree of respiratory distress, the driving of the child, gain in weight, feeding difficulties, etc. So not just only these data from the polysomnography. In our hospital, the management of these children is really taken on by a multidisciplinary team. All children will start with cardiorespiratory monitoring during sleep. In those with mild sleep apnea, we would recommend prone positioning with cardiorespiratory monitoring if the sleep study has proven that this prone position would be efficient enough. In those with moderate to severe sleep apnea, we typically first start with CPAP therapy, and this can be done by using a nasal mask or the OptiFlow interface, so the nasal prongs, which often are better tolerated by the children. And in case of CPAP intolerance or non-compliance, we would do an upper airway evaluation with drug-induced sleep endoscopy, as I will explain later on. We also perform a complete assessment of associated features, especially syndromic features. So we have the clinical geneticist involved, because we also know that syndromic patients are more likely to require surgical intervention and might have more severe sleep apnea. We look for cardiac anomalies, and we look for feeding difficulties with a pediatrician and a speech-language therapist. So the aim of the upper airway evaluation by drug-induced sleep endoscopy is to assess where is the site of obstruction, because often we see that children with Pierre-Robin sequence not only obstruct at the tongue base, but also might have palatal collapse both before and after palatal surgery. And literature has also shown that about 50% have also a laryngomalacia associated to their upper airway obstruction. So we feel it's important to have a good picture of this, and for that reason we perform this drug-induced sleep endoscopy, which is essentially a flexible endoscopic assessment of the entire upper airway during drug-induced sleep. So it's performed in the operating theater with the child spontaneously breathing. There is also, of course, a clinical assessment for the degree of microerythrognathia by our maxillofacial surgeon. So I will now show you some examples of DISE. The first is a child which is about 13 months of age. He already had his palatal closure. He was on CPAP treatment, but which went well up to the moment that he had an intercurrent respiratory infection. At that moment, he didn't tolerate the nasal mask anymore, and the parents failed to have him using it again. So you will see how we do this examination. So this is under induced sleep. Typically, we use propofol. Here you see the reconstructed, a little bit bulky, soft palate, which here you see the nasogastric tube. You see a collapse of the upper airway at the level of the tongue base. The tongue base is really pushing the epiglottis against the posterior pharyngeal wall. Here we do a jaw thrust maneuver, and then when we relieve the jaw thrust, you will see that there is also a pattern of laryngomalacia, with this very floppy and redundant mucosa collapsing and obstructing the glottic inlet at each inspiration. We then tried to assess what's the effect of the placement of a nasopharyngeal tube, and you will see this here. So there is still some obstruction at the level of the palate. The tongue base is pushed away. This is what you can see here, but there is still this collapse of the epiglottis against the posterior pharyngeal wall, and also the laryngomalacia is still present. So this child was then treated with mandibular distraction, and we performed the endoscopy later on to see whether he still would need a supraglottoplasty. And as you will see here, there is only this fluttering of the soft palate remaining, but there is no tongue base obstruction, no collapse of the epiglottis, and also there is a spontaneous improvement of the laryngomalacia in this child. So we feel this is an important diagnostic means, and also we use it in the follow-up of our patients. So the treatment for CPAP intolerant or non-compliant patients in our hospital is the use of a mandibular distraction with a Molina distractor, which is an external distractor. We can do supraglottoplasty in children with laryngomalacia, and tracheostomy is really reserved for severe cases. And I have to say that in the last 25 years, we never had to do a tracheostomy in any of our children. Here you see some examples of the Molina distractor. So this is placed externally. In the first week, the child will remain intubated in the PICU, and then the distraction goes with to achieve an advancement of about 1 centimeter or 13, 14 millimeters, which progress is made about 1 or 2 millimeters daily. The distractor then remains in place for about 6 weeks to have a good formation of a callus, and then this will be removed. So here you see the design. So the mandibula is cut. Here are the pins are placed, and then the distractor is activated. And this is a picture that I received from one of the parents. So you see here the child before the treatment with the nasopharyngeal tube, and then on the different days progressively, there is an advancement of the mandible up to the final day when we achieve the final position. So you clearly see over the course of a few days to what extent the mandible is progressively advanced forward. So what is the outcome? Since 2019, we treated 11 cases. 3 of them were syndromic. There is a very wide age distribution. And here you see some polysomnographic data. I focused on the post-treatment obstructive apnea-hypopnea index. You can see most of them obtained favorable results. This child still had an increased index with mainly hypopneas. She was treated with CPAP for a while, and then there was a spontaneous improvement. This child turned out to have also obstruction at the level of the tonsils when he was about 16 months of age, and he underwent a CPAP tonsillectomy. It's this one. So this is overall quite favorable results with distraction. The follow-up by the multidisciplinary team, we believe it's important to repeat a polysomnography also after the closure of the soft palate, because the soft palate closure might result in a narrowing of the upper airway, reassess the need for complementary treatment, and a yearly follow-up until the child achieves his adolescence. So in consideration, we think that syndromic patients, we know from literature that they have poorer outcome than those with an isolated Pierre-Robin sequence. The selection for surgery and the chance of a good outcome after surgery can be improved when we identify and address the etiology of the upper airway and really do this on an individualized basis. Patients with associated airway pathology, for instance, laryngomalacia or subglottic anomalies based upon prolonged intubation, should undergo a mandibular distraction as the initial approach. The reported incidence in our data, but also in literature, of complete resolution is relatively low with all surgical treatments. And we have further to assess what's the impact of long-term intermittent hypoxia and whether there is a role for additional medical treatment in this population of children with Robin sequence. And finally, I would like to thank all the participants and the colleagues of the multidisciplinary team at our Antwerp University Hospital. Thank you.
You're muted, Refika.
Okay, apologies. So thank you very much, Anne, for this wonderful talk. And now I'm very pleased to introduce our last speaker, Dr. Vasileios Patelis, who is a pediatric and respiratory and sleep consultant at Great Ormond Street Hospital for Children in London, UK.
Hello, thank you. Hi, everyone. My name is Vasileios Patelis. I'm based at Great Ormond Street Hospital, and I will be presenting the UK perspective for the management of Robin sequence and the experience of our unit. So, GOSH is the referral center for cleft patients in North London, and we do not have an obstetric unit. So the patients born with Robin sequence are referred to us by the neonatal teams from other North London hospitals. And the initial assessment is done by them with support by the GOSH cleft team, if there is a cleft present, and the respiratory team. The patients will be assessed clinically for obstruction, including signs of obstruction with sleeping, feeding, and different positions. And they will also have continuous oximetry or overnight oximetry, as well as blood gases while they're in the neonatal unit. And further assessment is then done at GOSH with respiratory polygraphy. If the neonatal team has no concerns with the initial assessment, meaning there is stable saturation, there's no clinical features of obstruction, then the patients, or if the patients are managed satisfactorily with positioning alone, and with positioning we usually mean side lying rather than prone positioning, then an outpatient referral for respiratory polygraphy is done, and the target is for this to be done around 6 to 8 weeks of age, as this can be when the obstruction can get worse, as I mentioned before. And in the meantime, patients will have a clinical review by the cleft team. On the other hand, if there are significant concerns such as frequent profound desaturations or high CO2 or clinical obstruction in all positions, then the nasopharyngeal airway, an NPA, is inserted in the neonatal unit prior to transfer to GOSH for polygraphy and further management. And finally, the remaining patients who have some obstruction but not life-threatening immediately would be transferred to GOSH without an NPA for an assessment and further management. We have been using respiratory polygraphy as our main assessment tool for obstruction for more than 10 years now, although noting that practice within the UK is variable and some units use oximetries mostly. We use obstructive apnea-hypopnea index to classify the severity of obstruction, as mentioned before, but this is an imperfect tool, and it should always be evaluated in conjunction with the other sleep study parameters such as oxygen saturations and CO2. And a clinical assessment of these patients is also important in classifying the obstruction severity. And for example, if a patient with an OHI of less than 5 would be classified as mild to SA normally, may be reclassified as having moderate obstruction if they have profound desaturations or hyperventilation, or if there are other clinical concerns. The first-line management for moderate to severe obstruction at GOSH and in the UK in general is with an NPA. And examples of which you see in the pictures, it's basically an ET tube, which is cut to size and inserted by the nostril, and it can either be done with a split tube, as in this picture, or with a cut ET tube stitched to a cut ET tube holder, as in the bottom picture. And we will check the position of that usually with a lateral neck X-ray, and the tip of the NPA should be above the epiglottis but after the base of the tongue. And then a repeat respiratory polygraphy is done with the NPA in situ. We do sometimes need to readjust the NPA length or the tube diameter to achieve the best results there. If there is persistent severe obstruction despite having the NPA, then we usually would go on to have a trial of CPAP. And if CPAP is also not successful in treating the obstruction, we would be referring the patients for tracheostomy. Mandibular distraction is not routinely offered in our unit as an alternative treatment option, although we do sometimes do it to aid decannulation for patients who have already had tracheostomy. With regards to the outcomes of our management strategies, this paper from 2012 describes our population from 2000 to 2010. There were 104 patients with ROB-N sequence, 18 of whom also had a syndromic diagnosis. Obstruction at the time was assessed with oximetry using McGill criteria. The patients with mild OSA were managed with positioning alone. There were 77 patients that had moderate to severe OSA who had NPA insertion, and the majority of those were managed successfully with NPA, with significant improvement in the obstruction, although 14 of them did have persistent severe OSA and required tracheostomy. The mean hospital length of stay was only 10 days for the patients who had NPA, and the mean NPA duration was 8 months, although this is a mean and it is skewed by a handful of patients with syndromes who had NPA for prolonged periods. And finally, this is my last slide. This is a recently published study for all patients with ROB-N sequence with cleft were born across the UK and Ireland from January 16 to January 17. And 173 patients were identified. A little bit less than half of them had non-isolated ROB-N sequence. And 2/3 required an intervention other than positioning alone. This was, as a start, NPA for most patients. And 1/3 of the total patients were discharged home with the NPA. And the median duration of use for the NPA for this cohort was only 90 days. 19 patients had a tracheostomy, which was after failure of other interventions such as NPA or CPAP. And some other short-term interventions were used. And CPAP was also used as a long-term intervention for patients who presented later. The median length of stay for the patients who did not have a surgical intervention was 26 days and 60 for those who received a tracheostomy. The study also looked at neurodevelopment, and they found that 18% of patients who had isolated ROB-N sequence had a neurodevelopmental delay. This was most commonly speech and language delay, although 7% of patients in total had global developmental delay. This was based on clinician assessment rather than a formal assessment, though, and it was found that neurodevelopmental delay was more common among patients who received a tracheostomy. And likely this is because it presented the more severe end of the spectrum. That's it for me. So hopefully we'll have some time for questions.
Okay, thank you to all the speakers for their, I think, quite different perspectives on management. I would also like to thank the speakers because they already addressed a lot of the questions in the chat. Perhaps I will start with one more open general question. I think the different centers used polysomnography or polygraphy, but we also have some colleagues where polygraphy or polysomnography is not available. So one of the questions, and I would like to address this to all the speakers, is what about the value of, for instance, oximetry or capnography in the diagnosis and management of these children?
But basically, you will only get the tip of the iceberg with those techniques. So without a sleep study, I would be hesitant to rule out relevant upper airway obstruction. That's sleep-related upper airway obstruction, obviously. And I mean, that's also an advantage of using polygraphy. I mean, polygraphic recording systems in Germany, you get them for between 15,000 and 20,000 euros. That's not a huge sum of money. I mean, it's a bit more than an endoscope, but you also won't argue about an endoscope. So, sorry, I'm not ready to compromise there. It's you need a sleep study, otherwise you don't know where you are.
I think we also, we see babies have pretty reassuring oximetry and CO2 levels. And then when we look deeper, we sort of unmask the poor quality of their sleep and, desaturations that are not being captured on our monitors. So that sort of unrecognized burden and long-term is what we get worried about without sort of more, but we also understand the access to sleep studies is not universal.
I think we can certainly agree on that. And there was also a question about the side effects, especially on pain of the mandibular distraction. Can you comment on that?
Well, the first week after the surgery, they're intubated in the PICU, so they are given pain medication. But then once once the surgery is done and the children are awake, then the prolongation is stabilized. So then it's not painful anymore. You don't need to turn the screws as soon as the child has been extubated and is awake. So they don't feel it when you're advancing the mandible. So it's not, no, and afterwards they just go, they are extubated, they stay a few days in the PICU, and then they go to the ward and they go home. So it's not, no. Probably the first week is painful when you have to turn the screws, but then they're intubated and under general anesthesia.
Okay. Another, I think, interesting question about perhaps one of the downsides of sleep endoscopy is whether the use of an endoscope gives a false impression because it could extend the airway in a way so that you don't.
Yeah, that's possible. But anyway, we use very slim, flexible endoscopes of about 2.2 millimeters or so. So it's really, I don't think that's really, they're not as thick as the nasopharyngeal airway anyway. So we cannot exclude it, but I don't think that you would miss a tongue-based obstruction just by inserting your endoscope.
And I think there are also, I know of at least one paper, I think, comparing DICE findings with findings from Cine MRI, and that they are very, very comparable. So a question for Dr. Poets is, I assume that when you use the plate, the children, they don't need CPAP therapy or additional treatments like that. So if they need CPAP therapy before the plate, it will probably be stopped after.
Exactly. Yes, that's exactly how it is. Yeah.
Okay. Let me see. A question about the rate of failure of palatal plates and what the most common cause for that.
As I said, in isolated rubella, we never had this. With some syndromic babies, if they have a swallowing problem, then they may run into difficulties because for the first few days of using this treatment, they often have more saliva, and if they can't swallow that saliva, that may get them into trouble. But this is really the only indication where this treatment really doesn't work. And perhaps another group of patients, a rare one, is where you have a share type 4 obstruction, so a circular obstruction of the larynx. That may also be a problem in some rare babies. For example, with Nager syndrome, we have had about 6 patients over the years, and in 3 we ended up doing a tracheostomy. So this is a group where we have a much lower success rate. But then these are rare babies. Nager, as you know, is a very rare condition.
And just to piggyback on that, I can't speak to the 20 years of experience that you have, Dr. Putz, but we've seen that the babies who are starting their plate therapy later, it's more challenging for them. So the 6-week-old versus the 6-day-old. And so trying to be really patient in that adjustment phase for those older infants, because we have babies come from so far, we don't necessarily always have them in the first month of life.
Yeah, good point. I mean, that's something you would wish for, and you just need to spread the word that you get the baby sent over to your center early, because it's really, my experience, the earlier you start, the earlier you are done. It's as simple as that. And it's not only 2 weeks earlier 2 weeks earlier, but you start 2 weeks earlier, you're done almost a month earlier with the treatment altogether, because the growth potential of the mandible is largest in the first weeks after birth.
This is Iris. I see a question here about the impact on the tongue for the orthodontic airway plate. I don't know if this has been answered in the chat, but probably Dr. Evans and Dr. Boats can make a comment for the group. The question is, what is the impact on the tongue at all? Breakdown, ulceration, abnormal development, and others.
No, honestly, we never had tongue problems. And with more than 600 patients, I think I have a relative good basis to make such a statement here. We see sore spots on the of the gingiva, of the gingival mucosa, and then you have to abrade the plate where these occur. But the tongue would imply that it is a problem with the spur, and that if you should not apply too much pressure on the base of the tongue with your spur, and you will get experience with that pretty quickly, in my experience. So I'm never worrying about the base of the tongue. I may worry about these sore spots in the area of the base plate on the maxillary side of the baby.
Our experience is the same.
And one more, I think this was answered also by Dr. Evans about the support system that would be provided for babies that are discharged to home, probably for our European colleagues.
We do send them home on a pulse oximeter, on a motion-resistant pulse oximeter, but there's no good data to back up this practice. But in theory, the plate may get dislodged, and then the baby may run into difficulties breathing. And obviously, you would like parents to become aware of that. That's my main reason. I have no data to back up this practice, but that's what we are doing.
Yeah, I also raise a question that was asked by Koen Justin from Netherlands, Rotterdam. He asked about the cutoff point to Dr. Poet.
Oh, yes. Sorry, Koen, that's one of these silly questions, because you are aware of this, you are a SIDS expert. So you know that you need 50 babies per group to prove that. And this is never realistic in Robin sequence. But I see no reason why a baby that is otherwise healthy, just has a small jaw, should be saved from the negative effects of the prone sleep position just because he has Robin sequence. I just can't see the reason, and I'm not prepared to expose a baby to the risk of the prone sleep position just because he has this diagnosis. And perhaps I have an easier position saying that because we have an alternative that is minimally invasive. So if you are in a setting where you don't have this alternative, before you tracheostomize the baby, which is also fraught with a higher risk of mortality, then you may refer to prone sleeping. But having said that, there is now a large body of data that the prone position will not cure the problem. So they still have upper airway obstruction. It may improve in some babies, but we have just completed a prospective study, and out of 40 babies, 9 got worse when placed prone. So you can't rely on this treatment approach, plus you have this higher risk of SIDS. So to me, this is not an alternative.
So yes, another maybe discussion for the expert panel discussion, because I think that's controversial. But my question was actually to the cutoff point of normal versus abnormal mild in the very young babies. So I just wanted to raise this because I don't think anybody has a perfect answer. We don't have, of course, never the perfect studies, but maybe again for the expert panels, I think that makes the approaches not very comparable when people are using OAI as opposed to OAHI and using different cut points for different treatment modalities. So maybe more studies with the similar approaches, at least when the panels meet to make a decision on this, although admittedly very challenging. Maybe it would be a good idea, just putting it out there.
Just would like to inform that there is a very recent paper by the group of Perez with Dr. Coutier and Brigitte Fourou, where they did sleep studies in a cohort of children with Pierre-Robin sequence, and they looked at how polysomnographic parameters changed over time, and I was quite happy to see that they used the same criteria as we have published in the ERS task force. And so what they saw is that some of these treatment children also had a spontaneous improvement over time when they repeated the sleep studies between 6 and 8 months. So it's an interesting paper that we should have a closer look to, I think, when making decisions and see how we manage these children. It's a very rigorous and detailed paper on this.
Thanks, Al.
And perhaps can I just add to the question about the normal values or the reason for the cutoffs? We published a study in sleep medicine about in 2013. First author was Pablo Brockman. And there the 90th centile for the mixed obstructive apnea index was 5.8. So this is slightly higher than the threshold of 3 we are using. The threshold of 3 corresponds to the 75th centile. So you may say that we are overly generous, and perhaps increasing the threshold to obstructive apnea index of 5 may be a reasonable alternative. As I said, it was a somewhat arbitrary decision.
Any more questions, Stan, from the audience?
I think we covered most of the parts. I don't think so that we have any burning questions left.
There is one question whether we would do a sleep study because of a small jaw, but I think it's not just a small jaw, it's a retrographic jaw, and of course also the symptoms of upper airway obstruction, but not a small jaw as such.
Mm-hmm. Okay, excellent. So this was a very lively, really interesting webinar. I would like to thank on the behalf of my co-moderators, all our panelists, and also the audience who have asked all these questions and made this webinar more relevant to their practice. I think more to come on this. Maybe we'll do this again in a couple years, but we'll also like to thank both ERS and ATS for their support. And I will close this webinar now. Thank you very much. Bye.
Okay. Bye. Thank you.